Good morning. It is my great pleasure for the Cardiology Grand Rounds number 2 of the year to introduce Steve Ferris. For those of you that don't know Steve, Steve is a longtime Husky in our eyes, but he actually came from Cal many years ago. Yes, secret thing about Steve, he is actually a golden bear. He grew up in Palo Alto, went to Cal, came up here for medical school after spending several years in research lab, honing his love for science. In medical school, spent an extra year in a Howard Hughes fellowship in David's lab, studying atherosclerosis, did fellowship, general fellowship, and in general fellowship became interested in heart failure, and then joined my lab looking at fibrosis. And through that, I'd like to hope that through that he became interested in different kinds of heart failure than systolic heart failure, did a heart failure fellowship, and now is at the VA where he sees a wide variety of heart failure. We train people in how to take care of somebody with systolic dysfunction due to methamphetamine abuse who has no support. But at the VA, he sees a much wider variety of heart failure and has developed an interest in heart failure with preserved ejection fraction, which he's going to talk about today. Thank you, Steve.
Good morning. I'm going to talk about heart failure and one of my interests. And as April said, we have very little instructions / tailoring to treat this syndrome. And it's frustrating as a clinician for the patients. So what I wanted to do today was go over a little bit of the pathophysiology of the syndrome and try and glean some insights about what are some of the failures of the trials and potential therapies which have been shown to improve outcomes. And so hopefully we'll learn a little bit and in the future have some more exciting results. This isn't working. Problems. There we go. It's stuck. There we go. I have no disclosures. So I want to go through a little bit of a review in the hemodynamics of heart failure with preserved ejection fraction. Some of the pathophysiology, it's immense. And so I want to go over the highlights, both from a cardiomyocyte and myocardial level, but also a little bit of the peripheral factors, some of the recent intervention studies, and some potential beginnings that might be helpful for these patients. And I'll be jumping around a little bit based on studies and pathophysiology and risk factors for the disorder. So it's a very big challenge. And when I talk about heart failure with preserved ejection fraction, what I mean is patients who have the syndrome of heart failure, elevated filling pressures, dyspnea, but they don't have valve disease, they don't have genetic cardiomyopathies, they don't have restrictive pericarditis or any other uncommon disorders. They have the thing that we see in clinic most of the time. And it is very prevalent. And if you look at, this is Get With The Guideline data, it's a couple years old. And these are real world patients. Clinical trial patients are not as ill. These are real world patients. And basically there's very little difference between reduced ejection fraction and HFpEF as far as overall morbidity and mortality. The modes of death are different, clearly. Up to 40% of death in HFpEF are thought to be non-cardiac. However, it is all related as a syndrome. The prevalence of HFpEF in hospitalized patients is increasing about 1% a year. So this is something that will be seen over and over again and is an unmet need. Some of the classic hemodynamic studies were done in the early 90s, looking at patients who had the syndrome of heart failure. However, by echo, they had preserved or close to normal systolic function. If you look at oxygen consumption, was markedly decreased in these patients. Now, this was only a few patients and 10 controls. However, this has been repeated several times in other labs, showing that all these patients have decreased oxygen demand, cardiac output, poor oxygen extraction. They cannot augment their stroke volume, and they have impaired chronotropy. These are all been found in multiple different studies. They did, Dr. Kitzman's group did invasive hemodynamics, and they showed at rest, the pressures are actually only modestly elevated. However, if you exercise in the cath lab, do minimal exertion, your pulmonary capillary wedge pressure triples almost, up to 25, much higher than normal patients. So at rest, their symptoms, they don't have many symptoms, their filling pressures are reasonable. But at exertion, which is essentially the syndrome of HFpEF, is markedly abnormal. Now, more recently, more fancy physiology has shown that patients with HFpEF have markedly stiff ventricles, and this is one of the points of the physiology which has yet to been tackled effectively. So some of the therapies for HFpEF were started based on the assumption that, well, if I treat somebody with low systolic function, this might be beneficial for patients with normal or near normal systolic function. Lots of animal models suggest that these patients or these animals had fibrosis, and multiple studies have been done trying to test the hypothesis of renin-angiotensin system inhibition or sympathetic nervous system inhibition. Now, I'm only going to show and talk about a few of them, however, there have been many. Charm Preserve was testing the hypothesis that candesartan would improve cardiovascular mortality and hospitalizations. And these are patients with an EF over 40%, okay? A third of them had an EF over 60, a third between 50 and 60, and a third less than 50. So a vast array of ejection fractions in this patient population, 3,000 patients. Clearly there was the primary endpoint was not statistically significant. However, there was a slight trend towards improved hospitalizations. If you look at the actual admission numbers, it's not a huge benefit. However, it was a positive study. Irbesartan, a similar trial, was neutral, however, as was other ACE inhibitor studies. Beta blocker studies have been neutral as well, looking at nebivolol. So overall, the inhibition of RAS so far was neutral at best, with signals in some studies for kidney injury and hypotension. Now, aldosterone is elevated in these patients, both in animal models and human studies. Other neurohormonal agents are not, it's not proven to be. So the group looked at whether or not spironolactone, obviously, which inhibits aldosterone, would improve mortality and heart failure. In dozens of heart failure models in animals, spironolactone cures heart disease. It improves fibrosis. It is a miracle drug. However, if you look at the patients in this study, again, over 40% was over 45%, sorry, was the enrollment criteria. And you could either be enrolled if you were recently hospitalized or if you had a BNP, which is slightly elevated. The BMI in this group was about 30. Unfortunately, the study was really neutral. However, again, there was a trend towards reduced hospitalizations, and the magnitude was not huge, but positive. The issue is, in this study and other studies, is that the groups or dissimilar in the regions. It's unclear why, but the group in Russia and the Republic of Georgia were much less sick. And they most certainly, as a group, did not have heart failure. They were mostly enrolled with slightly elevated BNPs, and they met inclusion criteria, however, were not as ill. The overall mortality in this group was much lower than the patients from the Americas. Irregardless of the impact that spironolactone had, these patients were not nearly as sick. This is true looking at their kidney function. Their creatinine was much better. Their response to spironolactone was reduced, both in a blood pressure and a potassium. So obviously there's multiple confounders in this study. Both the patients were not as sick, and there is a little bit of controversy whether or not all the patients got the drug, got proper follow-up. They did not have a consistent potassium change consistent with study drug taken. So now in HFpEF, instead of just taking a heart failure medicine with reduced ejection fraction and throwing it onto other patients, what is the actual evidence that these folks have elevated neurohormonal agents? Now, I looked it up pretty extensively, and I found one study with good data looking at this question. Now, on the left panel, we have different neurohormonal agents, norepinephrine, renin, epi, and aldosterone. And this is a retrospective study done out of Italy over the last 15 or so years, where they sent them for a tertiary care center. They took their labs, and then they followed them up. Clearly, the worse New York Heart Association class you are, the higher neurohormonal agents were. This is true for patients with low EF, mid-range, and above 60. Okay. If, however, you have PAF as in over 60, you did not have elevated renin levels, your epi levels were the same, you had mildly elevated aldosterone, and your norepinephrine levels were much lower. For these patients, even though this is referred to a tertiary center, high filling pressures, they don't have the same neurohormonal antagonist elevation as other patients. How about neprilysin? There are no studies except for this study in the RELAX trial, which looked at neprilysin levels in patients with heart failure with normal ejection fraction. This is our neprilysin levels as opposed to activity. And neprilysin, one of the things it does is breaks down active natriuretic peptides. It also breaks down other vasoactive medicines. And the thought is that elevated levels of neprilysin can be a contributor in the pathophysiology of heart failure. There was no difference in this study in 240 patients looking at neprilysin levels in these patients. So the results of PARAGON-HF, are they that surprising? Maybe, maybe not. This study was just published 2 weeks ago, looking at whether or not sacubitril valsartan reduced mortality and heart failure. And these are patients with an EF over 45%. There was 4,800 patients enrolled for 35 months overall. Again, the primary endpoint was neutral. There was a trend towards improvement with heart failure hospitalizations again. However, if you look at it, the number of patients with actual events was very similar. Now, the patients with a lower EF on the spectrum, they did better, probably because the patients who have an EF of 65% are markedly different from the patients who have an EF of 45%. And so the study is neutral and negative. However, there is still a knowledge gap and a missed patient group with ejection fraction in the mid-range. However, I think it's fairly clear that patients with an EF over 60% would likely not benefit. So I think there needs to be a little bit more understanding about the pathophysiology and the paradigm shift of this disorder. So once upon a time, this is how we knew it: high filling pressures and concentric hypertrophy. However, this is what I see in clinic: the older person with multiple metabolic risk factors, including lung disease, cardiac disease, of course, liver, renal disease, and skeletal muscle. It's first and foremost a disorder of limited reserve, and it causes increased mortality and morbidity due to that. However, it's obviously multi-system. Now, the next couple of slides, I'm going to go over a little bit of pathophysiology and just go over the highlights of the, oops, sorry, that was my bad. Pull up the cord. You think Eric, I pulled out the cord. Sorry.
Oh.
Thank you. Sorry about that. This is a cartoon of endothelium and the interaction in the interstitium with cardiomyocytes. Very simplified, but highlighting nitric oxide pathway and its utility through the cyclic GMP system. Cyclic GMP is thought to signal via the nitric oxide pathway and via PKG, protein kinase G, and it's thought to have many beneficial effects on adverse remodeling, hypertrophy, and fibrosis. Whereas chronic adrenergic signaling through cyclic AMP and PKA are thought to be harmful via multiple reasons, including calcium handling and other factors. There are also multiple fibrotic signaling pathways which have been shown to be important in animal models.
We lost
So, so the thought is, if you have increased cyclic GMP, decreased cyclic AMP, we're more likely to have improved physiology, such as decreased stiffness, decreased profibrotic signaling, and improved cardiovascular outcomes. These pathways are some of the main targets for future studies, which I'm going to go over quickly. Now, if you look at the vasculature, which is clearly a major component in this syndrome, some of the same signaling molecules and pathways are thought to be important for normal vascular biology. Again, you have signaling to the acetylcholine receptor, activating muscarinic, increasing nitric oxide, signaling to the guanylate cyclase pathway. Again, this is thought to inhibit calcium, inactivate this system, and cause vasodilation. Now, this is very simplified. However, these are some of the pathways that were targeted during future studies, trying to answer the question, can you signal through nitric oxide and cyclic GMP to cause vasorelaxation, both in the periphery, in the pulmonary vessels, And in the heart, does that improve myocardial dysfunction, improve relaxation, decrease cardiac fibrosis? Now, one of the things in the peripheral vasculature of these patients is that they're older for the most part. Most studies, the age is 65 to 70. They get hypertension is a major risk factor, but it's also a major element to the syndrome, and it is a very big contributor to the pathophysiology. If you have somebody with a stiff aorta due to hypertension, when you have forward flow in systole, the arterial waveform goes faster down the vessel tree and gets reflected backwards much faster because these patients have calcium and vasoconstriction. Now, that may not sound interesting, but what that does, in fact, is that it causes an increased load on the heart in systole as opposed to diastole. And over time, what that does is it reduces systolic function caused by fibrosis and other calcium handling like I talked about. If you reduce contractility, that will make your ejection slower, which will again make that reflected arterial pressure even worse. It is kind of a nasty forward cycle of pressure overload and contractility, and some people call this ventricular arterial coupling. So you have this progressive problem where you have a mid to late systolic load. This is thought to induce cardiac fibrosis and all the things that we've just gone over. In addition, this impaired pulsatility and wave reflection are thought to contribute to chronic kidney disease, cerebrovascular disease, and sarcopenia. So if these disorders are thought to be due to potentially impaired nitric oxide signaling, what is the data on the effectiveness in this? The RELAX study was one of the first to target this pathway in this group of patients, both looking at heart function, pulmonary vasculature, and systemic vasculature. Unfortunately, there was no benefit, and this is a small study, but well done, and published in JAMA, and New England Journal, and they showed absolutely no benefit in peak oxygen, score, 6-minute walk, etc. Go down the line. In fact, all the trends were either neutral or worse for these studies. What about isosorbide? We use isosorbide for HFpEF. However, targeting the nitric oxide pathways produced worse events. And this study was looking at activity. All it was doing was looking at activity, both in exercise capacity and what are you doing throughout the day, how much activity they were monitors to track their activity level. And what isosorbide produced was less activity. They felt worse, they had more syncope, and this is harmful. Now, if you combine hydralazine with isosorbide, which is also tried, 2017, looking at placebo, isosorbide, or isosorbide plus hydralazine, that was even worse. So if you are targeting HFpEF with these drugs, you're only likely to hurt them as opposed to help them. This is not using for angina as opposed, this is more to relieve dyspnea and potentially lower preload with nitrates. However, it was not successful. About inorganic nitrates, it's recognized from a basic science standpoint that it's not just all nitric oxide is synthesized through enos. There's also other inorganic reservoirs of nitric oxide, which are thought to be important in physiology. So there's these other group of nitrate molecules, not isosorbide, which are called inorganic nitrates. Barry Borlaug did a nice fancy cath lab study, which he always does, and they looked at, do you have a benefit hemodynamically of prompt isosorbide? And what they showed was, yes, you do. You have your PA pressures go down. And sorry, these are all patients with HFpEF. And there's 14 patients who get placebo and 14 patients who get inorganic nitrate. And across the board, through all the parameters of what we would figure to be beneficial, including lower PA pressures, which is here, lower the SVR, increase exercise capacity, increase workload on the cath lab, all a very promising trend. However, this study looked at inorganic nitrates just from an exercise capacity standpoint, since that is one of the major symptoms driving. And this study looked at patients who were separated into two groups. They got placebo for 6 weeks, and then they washed out, and then they got inorganic nitrate via an inhaler like albuterol. Looked at, okay, was your exercise capacity any different? Were your symptoms any better? Clearly, the difference was 0. No difference whatsoever. This is a paired data looking at all the patients with their own peak oxygen consumption. Looking at there was very little difference if they had placebo first or nitrate first, showing that the groups, it didn't matter if you got the placebo group or the nitrate group. Essentially, there was no benefit in exercise capacity. There was no benefit in symptoms of heart failure. One of the other things that nitrates may improve, thought to be, is heart failure. We give sildenafil for heart failure with reduced ejection fraction and VADs all the time with little to no data. It's a theory that if you offload the RV, that'll improve things. So how does RV dysfunction in HFpEF, how does that relate? So clearly RV function is a marker of advanced disease. Like the left side of the heart is multifactorial and systemic. If you have the predisposing risk factors, you can cause left ventricular remodeling stiffness. This clearly gives you left atrial hypertension, left atrial dysfunction, pulmonary hypertension, both post and over time, precapillary pulmonary hypertension thought to be due to a compensatory mechanism where you have abnormal peripheral vascular resistance, as well as just plain elevated pulmonary pressures. This causes RV pressure overload, hypertrophy. Increased RV strain tends to shift the septum, and that makes LV diastolic function worse, which is, again, making this whole circle worse. Clearly, RV dysfunction is a marker for worsening prognosis in kidney function as well. Worsening kidney function causes volume overload, which worsens RV function as well. What is the data on RV function in HFpEF? This is a busy slide, and it's a meta-analysis of several hundred patients, looking at echocardiographic evidence of RV function. And if you define RV dysfunction, not heart failure, by TAPSE 16, 1.6 centimeters, or fractional area change less than 35%. This was the prevalence in these studies. If you look at S prime, it was about 21%. So all kind of in that same 20 to 25% range. If you look at the mortality was increased for every 5 millimeters less than TAPSE, and for every small increment decrease in fractional area change. These are observational studies and clearly need to be explored more. Again, Dr. Borlaug's group in the Mayo Clinic looked at RV function and outcomes. Small study, about 90 patients. And they took controls and they took patients who they defined as having HFpEF. And they did echoes and heart caths. And they looked at what's the fractional area change and what's their mean PA pressure. Now, it's not that surprising that RV is impacted by high PA pressures. However, RV contractility is impaired in these patients because for every PA pressure, there is lower fractional area change. So RV contractility not just high afterload is a problem. Both work against each other. If you look at, which I think is interesting, the patients who had high systolic blood pressure had higher fractional area change, likely because they were able to mount the blood pressure because of their excellent RV function. I'm not sure that's very helpful. The patients who were defined to have RV dysfunction had a markedly worsening prognosis. Not completely surprising. However, this is pretty alarming. It's a small group, but it shows how sick these patients are. One of the ways where we can measure coupling of RV and LV is monitoring them invasively, looking at PA pressures. This is obviously looking at the Champion study, looking at pulmonary pressure monitoring. This is the overall study, which was a mix of patients, class 2, 3, and ambulatory 4, trying to test the hypothesis if you can diurese patients or adjust medicines to reduce their PA pressures, will it improve outcomes? There was a marked difference in decreased hospitalizations. 6-month study, very limited. If you look at the patients with preserved ejection fraction, again, even smaller study, but very promising. The patients who had the highest ejection fraction, over 50%, tended to have the most bang for the buck, for say, the lowest hazard ratio. All hypothesis generating, there's ongoing studies and outcome studies looking at this. Not actually giving a new drug, but changing the behavior of both the clinician and the patient. And that's something that I think I'm going to touch base on later. If you have elevated left atrial pressures with a stiff heart, is there a way to decrease that without hurting the patient? Because we know that isosorbide doesn't help, hydralazine doesn't help. And if you mechanically lower left atrial pressures by using a shunt, a left atrial pressure shunt, intraatrial shunt, an iatrogenic ASD, trying to see whether or not if you improve left atrial hypertension, you will decrease many neurohormonal maladaptive changes in the disorder. This was a pilot study, phase 2, looking at patients who have elevated wedge over 15 at rest or 25 with exercise in the cath lab, and importantly, looking at, well, there's a gradient from the left side to the right side, and they did not have severe RV dysfunction. If you have a shunt with an 8-millimeter device, you decrease their pulmonary capillary wedge pressure with exercise pretty impressively. Does this help? It's unclear. They did a 1-month study looking at exercise and change in wedge pressure. There was a small but statistically improved filling pressures with exercise. Again, they still went up, but it's unsure. There's currently a phase 3 study looking at this patient. And again, these patients had high left atrial pressure and modest right atrial pressure. Not all patients with HFpEF syndrome. This is a safety study looking at the patients who were tracked out to 1 year. And on the left side is all-cause kind of major adverse cardiac events, including renal dysfunction, hospitalizations. And on the right side was looking at hospitalizations. If you had one of these intraatrial devices, you were much less likely to be hospitalized. Very small number of patients, but promising with potentially impressive results. One of the things that is not addressed in heart failure is sarcopenia and cardiac muscle dysfunction. All the therapies looking at ACE, ARB, beta blockers, nitric oxide, potentially some of those have thought to be due to decreased inflammation and improve endothelial function. However, none of them have been shown to be helpful. These patients have marked impairment in skeletal function. If you look at biopsies of these patients, they have much less capillaries, and if you can mark that out to their peak VO2 uptake, if you look at the types of fibers, they're also markedly abnormal. these are versus controls in HFpEF patients. More recently, this group looked at, okay, yeah, the fibers are different, but how is the physiology? This group looked at 4 groups of patients. One were normal controls on the left. One were patients with heart failure with reduced EF, the class 1 symptoms. The patients with reduced EF and class 2 and 3 symptoms. And then the white group was preserved ejection fraction. And they looked at what is the exercise, and to kind of get rid of the fact that you may have a cardiac output problem with exercise, they did calf exercises. So really they're looking at calf exercises. It probably doesn't take a lot of cardiac output to do calf exercises. They looked at the exercise time was markedly worse. The amount of work they did was much worse. If you look at rest, ATP cycling was normal. However, if you exercise them, their ATP dysfunction was markedly worse and worse than these patients. If you look at the rapidity for ATP measured by NMR, it was also much worse than any of the other groups. These patients also had markedly elevated fat in their muscles, and again, much worse than the heart failure with reduced ejection fraction patients. Suggestive that they have a unique myopathy as opposed to just a comorbidity. Now, I touched on a little bit of behavioral change and changing diuretics. How about patient behavioral change? One of the most difficult things I think we have is trying to tell our patients to exercise, because it's difficult to change your behavior. They will much like to take your medicine. However, in this syndrome, I think it would be much more effective to spend the 20 minutes telling them to get off your butt and walk around, and maybe even have a walking appointment, because no medicine has been shown to reduce symptoms except for Lasix in this study. Lasix doesn't improve mortality. There are some potential benefits in reducing mortality with exercise. This is a meta-analysis which showed that exercise, meaning several weeks of doing treadmill exercise, which is supervised, that's it. It showed improvement in oxygen uptake, slight improvement in symptoms of heart failure. If this was a medicine, this would get full publicity on Times Magazine. If you look at dietary changes and exercise, this group looked at the combination of them. And what they did was they used a nutritionist to estimate the caloric intake of a patient based on their size, and they calorie restricted them, 300 to 400 calories a day. And they also had an exercise arm. And the question was, will exercise improve VO2 max? Will diet improve VO2 max? And is there a synergistic effect? Now, there are only 100 patients in the study with 25 in each group, but diet, calorie restriction, modest, with about 5 kilogram weight loss over about a 6-month study, improved their VO2 max substantially. Exercise, similar, and the group that had both interventions, it was an additive effect. This is not powered, and there was no time for looking at heart outcomes. Because of all this, the pharmacological studies that are ongoing and all the different phenotypes of heart failure, whether you can have a 75 or 80-year-old person with a small ventricle versus a 50-year-old person with a EF of 50% and an RV that's blown out, it is a different patient population versus somebody with a BMI of 50 and who's short of breath. All different patient populations. And several groups have tried to look at, well, everybody gets enrolled in a trial, but really their physiology may be markedly different. So Dr. Shaw's group, Northwestern, I should say, is trying to, amongst other groups, trying to look at, well, if we deep phenotype these patients, maybe we can actually define the syndrome better and enroll patients better, as opposed to just saying, okay, they're short of breath and their EF is normal or almost normal. And so they looked at deep phenotyping with renal function, CBCs, echoes, looking at RV function, LV function, Doppler indices, weight, vital signs, trying to characterize these patients. They came up with, based on machine learning, looking at 3 different overall profiles of these patients. Obviously, there are 3 groups. The first group, looking at patients who are mostly short of breath with exercise. They tend to have normal renal function, hypertension, mild obesity, and diabetes. Group 2 are the patients with much more volume overload, much more obese. And group 3 are patients with RV dysfunction and CKD. Clearly, quite a different patient population. These top 2 groups tended to be more obese, tended to have lower BNPs as group 3. So I think if we're trying to look at the spectrum of this patient with all the comorbidities and impacts, it's hard to know if looking at animal models and other studies answering 1 or 2 basic physiology questions. I think animal models are helpful. However, I think if you look at the overall trend of these studies, it's hard to replicate somebody aging 60 years. I think those are the main difficulties until we have pills or treatments which can reverse aging, reverse calcification of vessels, reverse collagen deposition in the heart, replicate cardiomyocytes, grow glomeruli. I think we're going to have a difficult time. So I think in summary, unlike HFpEF, HFrEF, which is mostly a neurohormonal disorder, HFpEF is related to comorbidities, both as risk factors and direct contributors to the syndrome. They're highly variable, and the comorbidities are important to cause the disorder and should be not ignored but treated aggressively. Now, treating a comorbidity such as hypertension has not been shown to improve outcomes in this disorder. Treating diabetes with SGLT2 inhibitors is currently being investigated. The studies, the Canvas studies, they enrolled thousands and thousands of patients, I think about 30,000 patients, with about 10 to 15% prevalence of heart failure in the studies. They didn't do echoes, and so they don't know what their ejection fraction was before the study. And a lot of times they don't have data on, okay, what is the ejection fraction when they're in the hospital? The Canvas group looked at that, and there were both patients with heart failure with reduced EF and normal EF, although it's not really helpful to answer the question whether or not it reduces heart failure admissions with preserved ejection fraction as dapagliflozin might in reduced ejection fraction. So should alternative avenues of therapy be pursued? I think we should potentially use some of this information to look at what are we doing and where should we put our focus, although it is difficult. Skeletal muscle repairs. We know that. We exercise, we hurt, we're better in 3 days. This may be where we get the biggest impact of this disorder as opposed to other pharmacological therapies. All right, thank you very much. Okay. I think, number one, the patient should be as uniform as possible. The patients who have ejection fraction over 60% are different than the patients who are less than 50 and over 40. And the patients in the middle are different as well. So that would be my number one suggestion. Number two would, I think, reduce admissions and morbidity. Every time we have a patient be admitted to the hospital, they get screwed. They have complications, right? Right? And whether or not that's because of patient errors or just the fact that they're sicker, and there's lots of variables. So I think that's a very important outcome, and probably very important to the patients as well. A lot of folks in their 70s and 80s are okay if they die, but they don't want to be miserable. So I think that's important. All of it may be true. I think the gold standard is the right heart cath. And looking at that shows elevated filling pressures at rest or with exercise, and symptoms and signs of heart failure. Do they have edema, and do they have orthopnea? Do they have fatigue? Problem is that because they're overweight, because they're maybe frailer, and they have dyspnea, we chalk it up to X, Y, and Z. That's part of the problem, is it's part and parcel of the syndrome. And so it's hard to differentiate, because not only is it a risk factor, but it's also a contributing component of the disorder. So I think because there are no therapies which improve mortality, we have therapies which improve symptoms, including diuretics. We may have therapies which improve outcomes with these newer diabetes drugs. I think we should focus on the therapies that we know works and tell them this is what works, and I don't know what to do after that, because we don't have the nutrition or the exercise support, which is where I think we should focus our time.
Population understands lower there. We teach people about their blood pressure, they can take their blood pressure, no wonder it's trouble enough. Now, with heart failure, exercise, with the perceived ejection fraction, what is it that we could teach the general public to monitor and relate to see if they're getting better, staying the same, or getting worse? Would seem to me that would affect their behavior, whether they're going to exercise and do diet. We need some kind of tool there for the general.
So the question was, are there any thoughts about how do we monitor patients and inform the public with this disorder, HFpEF? I don't have a patient self-monitor. I mean, I think elevated heart rate at rest is a sign of poor vagal tone and poor exercise capacity and poor exercise reserve. That's one. And then I think a lot of them are weights and just symptoms. A lot of patients ignore things. And so I think it's important to validate their symptoms and try and teach them, well, if you're not doing well, let me know. But if you're, things like that. But I don't think there's any like objective measure with this disorder, or a lot of things. The BNP correlates with filling pressures, but it depends on the weight and the amount of obesity you have. And so BNP is a marker, and I track that to help me with volume, because sometimes it's difficult. That's not been shown to be effective clinically in reduced EF, and it hasn't been looked at that I know of, preserved ejection fraction. I use it on myself because I think it's a tool and I should use it, so it can maybe help me. Sorry.
Differences that maybe one of the subgroups is better in some of the failed trials to suggest that some of the arguments to that heterogeneous group, if you just cluster them together, have one therapy that works well. Very suggestive of that.
No. And the difference is that the average BMI in, say, Top Cat was much lower than a lot of patients. And that group was either just hypertension alone, but they didn't have as much obesity and cardiorenal syndrome. And part of those studies is you can't enroll a patient to put them on spironolactone with the creatinine too. And so I think the patients with normal renal function and normal RV may actually benefit the most from this left atrial unloading philosophy. Patients with RV dysfunction and potentially uncoupling may benefit the most from pulmonary pressure monitoring. And so I think that's maybe something that we could look at. Yep. And that's
I think there is evidence that exercise benefits.
no, I do think that it. Yeah, I agree. Yeah, I agree.
What is the advantage of lumping all these patients together into one focused syndrome?
So the question was, what is the advantage of doing phenotyping?
No, we already know.
Yeah.
We know a lot of physiology, so heterogeneous, different etiology, different response to therapy. What's the advantage of saying we're going to take all these heterogeneous population and other heterogeneous populations and lump them together?
My intention, I think the intention was to differentiate them more effectively. That was the intention of this study. So by the phenotyping, you would differentiate patients with worse heart failure, worse RV dysfunction, more obese. The more obese patients have low BNP, as you talked about. Maybe those aren't the patients that you would want to put on sacubitril valsartan, because their neprilysin activity isn't high. So I think that's helpful to try and understand how to target therapies. It's a great idea.